Over the last 10 years, the Department of Radiology at the University of Florida College of Medicine has conducted a simulation-based evaluation of radiology resident competence in critical care imaging. 243 residents interpreted this case of mucormycosis as one of 65 cases during an 8-hour simulated on-call shift with a median score of 2 out of 10 and an overall average score of 1.45 out of 10. On average, 8.18 points out of 10 were lost due to missed observations. At the same time, 0.20 points out of 10 were lost due to interpretive errors. We define an effective report to be one which achieves scores between 7 and 10. In terms of letter grades, this would be A and B. In this most missed case, 1% of residents produced effective reports. We define a report having a critical error to be one with scores between 0 and 2. In terms of letter grades, this would be F and D. In this most missed case, 93% of residents produced reports with critical errors.
This 72-year-old male diabetic presented to the emergency room to our comprehensive stroke center as a stroke alert. The reason for suspicion of stroke was the acute onset of a facial nerve weakness on the left side. However, the facial nerve weakness was characterized as a lower motor neuron weakness and not one that might be related to an intracranial event, at least an MCA, kind of an infarct. So that's a bit of a tip-off in that this might not be a usual case. In doing this is part of our this was part of our stroke alert workup. He had a non-contrast CT. This, of course, is images that are lifted from the CT angiogram and perfusion study of the brain. And the most immediate and important finding on this is the infiltrating mass in the nasopharynx. Clearly, these are normal tissue planes over here. These are clearly infiltrated, and the carotid artery is here, and the carotid artery here is obviously compressed and surrounded by this abnormal tissue, which is then invading the skull base. It is eroding the clivus. It is eroding the inferior petrous apex and encasing the distal internal carotid artery. Below the carotid canal, and then within the carotid canal. You get a better feeling for its relationship to the central skull base on the coronal reformations here, with in the region of the petrous portion of the carotid canal. You can see the carotid here. The bone is gone. The bone gone there, and as we pan back and forward, there's an obviously large defect in the central skull base caused by this erosive infiltrating process. So we have a diabetic person, we have an infiltrating process in the skull base, and the primary working diagnosis at this point, without retropharyngeal nodes or other pathology and a relatively acute onset, is invasive mucormycosis. With regard to the facial nerve deficit, it being peripheral, then the next thing that would be reasonable to explore is whether there is continuity between this disease that's invading the petrous apex, eustachian tube, etc., and the facial canal. So here on the bone windows, the normal carotid canal, here it's eroded. Here's the eustachian tube filled with this abnormal invasive process. Higher, you can see the erosion of the skull base and the disease process here. We're almost coming up to the region of the facial canal. So here's the labyrinthine, sort of the labyrinthine segment of the facial canal right here. There's the labyrinthine segment, and you'll see there's lots of tissue here that isn't here on this side, and that's true of the section above, abnormal tissue here. So this abnormal tissue that was in the petrous apex just tracked up along the petrous apex and went on to involve the facial nerve directly at the first genu. Here's the region of the first genu here, and here's all this abnormal tissue that infiltrated the facial nerve at that point. So that explains why the patient had a peripheral facial nerve palsy rather than a central nerve palsy, and the patient did not have a cerebral infarction, but in fact had invasive mucormycosis with carotid occlusion, and the facial nerve paralysis being explained by further infiltration of that disease. We talked to the stroke alert team as well as the emergency room docs, explained the situation. It was determined that this patient's diabetes was significantly out of control, which is often the case with invasive mucor in the sinonasal region and nasopharynx. In this situation, he was admitted and treated with antifungal therapy. His blood sugar was normalized as best it could be, and he did well with, I think, eventual recovery of the facial nerve function, or at least partial recovery.